Acute heart failure. Acute heart failure is a clinical syndrome in which the heart is suddenly unable to maintain adequate cardiac output to meet the body's metabolic demands. It may be the first presentation of heart failure or an acute decompensation in someone with pre-existing chronic heart failure. Peak incidence. Acute heart failure is a leading cause of hospital admission in individuals over 65 in the UK. It is more common in people with a history of heart failure or prior cardiovascular disease, for example, myocardial infarction. Incidence may increase during winter months due to respiratory infections exacerbating chronic heart failure. Pathophysiology. Acute heart failure can result from a sudden event, for example, myocardial infarction or valvular rupture, that impairs the heart's pumping ability. In left ventricular systolic dysfunction, the failing ventricle cannot effectively eject blood, leading to increased left atrial and pulmonary venous pressure and ultimately pulmonary edema. In diastolic dysfunction, impaired ventricular filling due to stiffness or reduced compliance leads to increased filling pressures but preserved ejection fraction. Raised pulmonary capillary pressure forces fluid into the alveoli, resulting in hypoxia and respiratory distress. Reduced cardiac output leads to organ hypoperfusion, activating compensatory systems. The renin-angiotensin-aldosterone system, RAS, and sympathetic nervous system promote vasoconstriction, tachycardia, and fluid retention, which may worsen congestion. Symptoms: dyspnea, especially orthopnea or paroxysmal nocturnal dyspnea, reduced exercise tolerance, peripheral edema, for example in the ankles and sacrum, fatigue and lethargy, persistent cough, which may be productive, and abdominal distension or discomfort due to ascites. Signs: tachycardia, elevated JVP, jugular venous pressure, bibasal crackles or wheeze suggestive of pulmonary edema, cyanosis or hypoxia, peripheral pitting edema, hypertension or hypotension in shock, and displaced apex beat in chronic or severe cases. Diagnosis: initial assessment. Take a comprehensive history and perform a targeted examination to distinguish between new onset acute heart failure versus decompensated chronic heart failure. Investigations: ECG. This is used to identify ischemia, arrhythmias, or previous MI. Chest X-ray. This is used to assess pulmonary congestion, cardiomegaly, and pleural effusions. Blood tests: full blood count, UNEs, LFTs, CRP, troponin, BNP or NT-proBNP are helpful for diagnosis. BNP over 100 supports the diagnosis. Echocardiography. This should be performed within 48 hours in patients with BNP elevation. It is used to assess structural abnormalities and ejection fraction of the heart. Complications: cardiogenic shock. This causes reduced perfusion and is potentially fatal. Pulmonary edema, which can lead to severe respiratory compromise. Worsening of chronic heart failure. Acute kidney injury, AKI, due to reduced renal perfusion or diuretics. And hypoxia and multi-organ dysfunction. Management: initial non-pharmacological measures. Non-invasive ventilation (NIV). You should consider in patients with cardiogenic pulmonary edema not responding to initial medical therapy. Invasive ventilation. This may be required in cases of respiratory failure, reduced consciousness, or fatigue from respiratory efforts. Initial pharmacological management. Oxygen therapy. Maintain SATs between 94 and 98%. Intravenous loop diuretics, for example furosemide. First line for fluid overload. Higher doses may be required in those already on oral diuretics. Monitor renal function and urine output. Inotropes, for example dobutamine. This is indicated in hypotension or shock with poor perfusion. Vasopressors. These may be required if inotropes alone are ineffective. Avoid routine use of nitrates and opioids in acute heart failure. This is not supported by current guidance. Post-stabilization management. Beta blockers. Continue or initiate unless contraindicated. For example, bradycardia less than 50 beats per minute, AV block, cardiogenic shock. ACE inhibitors or ARBs. These are for patients with heart failure with reduced ejection fraction. Start once the patient is hemodynamically stable. Monitor renal function and potassium. And identify and treat the underlying cause. For example, arrange valvular surgery if severe structural disease is identified. That was just a preview. Watch the full video and hundreds more at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today